Thank you for joining Henry Ford Transplant Institute, our ground rounds. Today we have Dr. Koji Hashimoto from Cleveland Clinic. It's my pleasure to introduce Dr. Koji Hashimoto. He is a professor of surgery in Case Western University, and also he is the surgical director of the liver transplantation. So Dr. Hashimoto earned his MD and PhD in Kyushu University in Japan. It's like west side of Japan. It's one of the biggest transplant centers and one of the most famous university hospital in Japan. And then where he did the training of the surgical residency. Then also he earned the PhD on the biology field. And then he moved to the US and he did the transplant fellowship in the Cleveland Clinic from 2006 to 2008. And then he became an attending surgeon at Cleveland. Also he leads one of the largest liver transplant programs in the United States. Cleveland Clinic does over 200 liver transplant per year. And then Cleveland Clinic does the over 20 living donor liver transplant per year, which is also the largest experience in the country. So his research focuses on the living donor liver transplantation, as well as a transplant allograft rejection and ischemic perfusion injury. So Dr. Hashimoto's innovative work not only seeks to expand donor pool, but also aims to enhance the safety and effectiveness of liver transplantation. So join me in welcoming Dr. Koji Hashimoto, and then you're going to listen to his talk about living donor liver transplant. His talk title, How to Overcome Size Mismatch in living donor liver transplantation.
Good afternoon. Thank you so much for inviting me to such a prestigious transplant center. It's my honor to be here, and I'm very, very excited to share my experience of living donor liver transplantation. So as we all know, the liver is the organ that can be divided into 4 major segments and 8 subsegments. So as far as you have the 4 essential components, which are the venous outflow, portal inflow, and the hepatic artery inflow, and then finally the biliary system. You can take any size of the liver and then put into the recipient as a transplant. So this is a partial liver transplant. So that's why we can do a living donor liver transplantation. So the living donor liver transplant, there are 3 major types of liver. So the first one is the left lateral segment, which usually goes 15 to 25% of the liver. And this usually goes to the small children. The left lobe is a 30 to 40%. And the right lobe is the largest graft you can take from the human. And then usually the left lobe is 30, 40, and the right lobe is 60, 70%. It usually goes to the adults or teenagers. And as an uncommon graft type, we can also take right posterior graft, which is a segment 6 and 7, and the right extended graft with the middle hepatic vein. Or when you have a tiny, tiny baby, you can do a left lateral segment reduced size, and also the mono segment, either segment 2 or segment 3. So this slide shows the number of liver transplantation in the country over the last 20 years. So as you can see, the number of liver transplantations steadily increased, because of the all efforts we made. So in the last year, finally we reached more than 10,000 liver transplantations in the country, which is great. And if you look at the living donor liver transplant activity, compared to the 20 years ago, the number almost doubled. However, you look at the proportion of living liver transplant. We have only 6.2% of the liver transplantation done from the living donor liver transplantation. So why is living donor liver transplantation so underutilized? So we have reasonable number of deceased donors. So the people say we don't need to use the living donor. And there is a well-publicized donor risk. So for example, if you do 500 liver transplantation from the living donor, you may have 1 living donor death. So generally speaking, the mortality of the living donor is 0.2%. And the living donor liver transplantation is technically more complex than the deceased donor transplant. You have an increased risk of surgical complications. And then there's a unique risk of surgical complications, which is a graft failure due to donor recipient size mismatch. We call small oocyte syndrome. And finally, there is a fear for the inferior graft survival using the living donor. But if you look at the real world, actually the outcome of living donor liver transplantation is not so bad. So if you look at the SRTR data here, from 2012 to 2018, so there is no adjustment on the data. So the graft survival of the living donor liver transplantation was as good as the brain dead donor, and also much better than the DCD donor transplantation. And because there's no risk adjustment, the living donor recipient had lower MELD score, so they had a better background compared to the DBD and the DCD. The living donor liver transplantation patient had higher risk of surgical complications, but they had earlier and higher rates of return to work for income, and also they had a less chance to have a chronic kidney failure after transplantation. There are so many benefits doing living donor liver transplantation. And even after risk adjustment, so the living donor liver transplant has a great benefit when your patient MELD score is less than 15. And actually, this study, I think, is from Dr. Nagai. It's a wonderful work. This is clearly say that we have a great benefit doing the living donor liver transplantation. Even we have a reasonable number of deceased donor. So this slide shows the number of liver transplantation that Cleveland Clinic main campus in Ohio. So since 2004, we have been using both living donors and deceased donors as a very variable organ source. And interestingly, recently, we have been using machine perfusion, homothermic machine perfusion very heavily. And if you look at the data in the 2023, about 80% of the livers were pumped before implantation. So we no longer do a transplantation overnight. For almost all cases, starting in so the life of transplant surgeons are changed. So interesting, as we use more machine perfusion, the number of living donor transplantation starts going down. I think there are many reasons. But if you look at this slide, a few years back, we had about 20% of the patients receiving a living donor. Now we have 10% patients receiving a living donor. So what's the best practice with a living donor liver transplant? I strongly believe that we have to identify a patient who really needs a living donor. And once we identify it, we have to create a dedicated team for living donor. Because the living donor liver transplantation practice is very different from the deceased donor transplant. So you cannot do a living donor transplant just as a side business of the deceased donor. You have to have a dedicated team for living donor transplant. And once you create the team, this team needs to master how to maximize donor safety and the recipient outcome simultaneously. So who need a living donor liver transplant under the MELD score allocation? So when your patient's MELD score is high, you really don't need living donor liver transplant because they have a great access to deceased donors, unless your patient is small or female, because the small patient has a very small domain of that. So the large deceased donor liver won't fit. So they cannot have the timely transplantation because of the size. But when your recipient's MELD score goes lower, the importance of living donor liver transplantation increases. As you can see here, the patient with a low MELD score have limited access to deceased donor organ. So they have a longer waiting time, and there is a significant risk of dropout from waiting. So those patients include someone who has a low MELD score with a very poor quality of life. with ascites or varicose bleed or hepatic encephalopathy. For somebody who has HCC or unresectable malignancy, like colorectal cancer, liver mets, or intrahepatic cholangio. So this study shows the, this is from the UNOS data. So this study shows the disadvantage of being a female on the weight. As you can see, the female sex has 10% increased risk of dropout from the weighting. So I think my interpretation on this study is the female people have small body abdominal domain, so that they are not able to receive the big donor. So that increased the risk of dropout from the weighting. So here's another UNOS data showing the benefit of living donor liver transplantation in an HCC patient. So after listing, there is a great benefit of graft patient survival using the living donor with a shorter waiting time compared to the deceased donor transplant, or there's no chance of transplantation. So time matters when you have an HCC patient, and then living donor liver transplantation works with this situation. So again, who needs a liver transplantation the most? So the patient with who has a small body, a shorter height and a lighter body weight, or low merit score with poor quality of life, somebody who has HCC or hepatic malignancy like unresectable colorectal cancer, liver mets, or intrahepatic cholangio. Well, of course, I didn't show you the data, but pediatric recipient has a really great benefit. So here's the best approach in the living donor liver transplantation in Cleveland. So I think we need to shift the risk from the donor to the recipient. By taking the risks away from the donor, we put these risks on the recipient. So to do so, we have done this approach. We use the smaller left graft as the first choice in adult living donor liver transplantation. And they use larger right graft as an alternate. So this is the principle over the 20 years in my program. So to make this happen, we have a very careful graft recipient management. And also we have introduced a very innovative surgical approach to increase the functional graft size, which I'm going to show you in this presentation. And then finally, we also started the minimally invasive donor head to further increase the donor safety. So this slide shows the size of the future liver remnant. For example, if you take left graft, you can leave the 60 to 70% of the big liver in the living donor. But if you take a larger right graft, for the sake of recipient outcomes, you only leave 30 to 40% of the liver in the donor. So this remnant size determines the donor risk. So this slide shows the highest total bilirubin and the highest INR after living donation. As you can see, after right lobe donation, the donor's bilirubin INR goes significantly higher than the left lobe donation or left lobe donation. So basically, after right lobe donation, there is a great risk of liver failure in the living donor. But if you look at the national data from SRTL database, the majority of centers still using the right lobe graft, predominant. And the left lobe graft is still a minority. But we have a very different approach in Cleveland. So from 2005 to 2023, we have done the 221 adult living donor liver transplant, and 100 patients received the left lobe, which accounts for 45%. And then 53% of the patients received the right lobe. And there were 4 cases we used the right posterior segment 6 and 7. So to use a small graft, it's very important to understand what's the portal hemodynamics in the cirrhotic patient. So when somebody develops cirrhosis, they have higher pressure in the portal, and they become very hyperdynamic. with increased cardiac output. So when you take the right lobe graft from the living donor, in the donor, this right lobe graft receives the physiologic portal vein flow. But once you take out and implant it into the recipient, so this right lobe graft receives a super high portal flow in a very toxic environment. And this slide shows the distribution of the portal vein flow, which is standardized by the graft weight. So as you can see, the median portal vein flow in the deceased donor transplant is much lower. So if you merge to these figures, you can clearly see the portal vein flow in the living donor graft is much, much higher than the deceased donor whole graft. So what happens if you have such a high flow in the small graft? So the patient may develop the complication we call small foci syndrome. And actually, this syndrome was first described in 1996 by Dr. Johnny Mott when he was in San Francisco. So this is very interesting. So he described that this syndrome is characterized by the significant functional impairment associated with paradoxical histologic changes, typical of ischemia. So when I read this paper, it really didn't make sense because the graft received such high portal flow. But why the liver graft gets ischemia? So it really didn't make sense. But 10 years later, the group of Pittsburgh found out pathophysiology of the ischemic change in the small foci graft. So when the small graft received excessive portal flow, this portal hypoperfusion causes hepatic artery spasm. And then the hepatic artery flow diminishes in the graft. So that's why the liver ischemic change, because the liver graft loses the hepatic artery because of such a high portal flow. And this happens because the liver has the hepatic artery buffer response, meaning when the portal flow is high, the liver auto-regulates the hepatic artery flow. And then when the portal flow goes down, hepatic artery flow goes up. So in the situation with a small graft receiving such a high portal flow decreases the hepatic artery. And that's the reason that small graft gets ischemic. So on the left side, this is the normal waveform in the hepatic artery after living donor liver transplant. You have a nice systolic upstroke with normal diastolic flow. But if the small graft receives the excessive portal flow, you still have a sharp upstroke in the systolic phase. But in diastolic phase, you lose the complete hepatic artery flow. You lose completely. And then this flow reverses to backwards. So meaning in the diastolic phase, the hepatic flow has the reversal flow. So this is the hepatic artery insufficiency because of the portal hyperperfusion. So this happens in the small size graft. So clinically, the patient with small foci syndrome have the persistent jaundice, coagulopathy, ascites, mental status change. And eventually they develop the renal failure and sepsis. And this causes a lot of resource use and longer hospital stay, and they increase the risk of graft loss and mortality. But once the small foci syndrome happens, the outcome is very dismal. And unfortunately, there is no good treatment to reverse the situation of small foci syndrome. So the best treatment for small foci syndrome is to prevent it occurs. So we need to understand what's the risk factors for small foci syndrome. So now I want to introduce you the concept of functional graft size. So please imagine that the size of this pentagon is the minimal requirement, minimal functional graft size to prevent the small foci syndrome. So this functional graft size will be determined by 5 important factors, including actual graft size and the graft quality, like a donor age or biopsy results or ischemic time, and how sick your recipient is. So the recipient is severity based on the MELD score, child score, for medical urgency. Graft portal inflow and venous outflow. So let's take a look at this case. The living donor, the healthy 24 years old man, donating the right lobe graft with a graft recipient body weight ratio of 1.0%. So which is a fairly big graft. Biopsy shows no steatosis. And there's a large dominant right vein, so the venous outflow must be. And the segment 5 and 8 vein will be reconstructed on back table. So the recipient is a 55 years old male, alcoholic cirrhosis, HCC with imbalance. So no ascites, child score is A, and the male is only B. So he has a very minimal portal hypertension. So the functional graft size of this case is like this. This patient had a large graft, beautiful liver graft with a younger donor age, no steatosis, low MELD score, minimal portal hypertension, and excellent venous outflow. So the functional graft size of this case is way bigger than the minimal requirement. So that means that this case is likely to be successful with very minimal risk of small size syndrome. What about this case? The living donor is 48 years old, BMI 34. The donating the left lobe graft because the future liver remnant of right lobe graft is only 26%, so 30%. So there's no way to donate right lobe. So left lobe graft with a graft recipient body weight ratio of 0.75%, so which is small graft. So the left, because this is the left lobe, the graft has a single venous outflow with a common trunk of left liver. So the recipient is 61, MASH cirrhosis. This patient needs a frequent volume paracentesis because of ascites. The history of GIP, the MELD is 23. So this patient is much sicker than the first patient. So here's the functional graft size. The graft size is smaller. The graft quality is not as good as the first one because of the donor age and the high BMI. The MELD score is much higher, and this is a child with CK, severe portal hypertension, and an OK venous outflow, the left lobe. So the estimated functional graft size is much smaller than the requirement to prevent small size syndrome. So now, so the question is what to do. So we can say the three things to donor and recipient. We can just discourage them. Say, I'm sorry, we cannot do this case because there is too high risk of complication. Or we can use a right lobe graft instead of a left lobe. But in this case, the remnant liver with the right lobe donation is too small to donate. Or you can ask your recipient to find another one, which is not easy to do. So we can either cancel this case. Right. But good news is this functional graft size can be surgically maximized. So once you identify donor and the recipient, so those three factors, graft size, graft quality, and the recipient disease severity, those are not unmodifiable. Those are not modifiable. But the good news is graft inflow and graft outflow can be maximized with surgical technique, with a portal inflow modulation to reduce the portal flow, or venous outflow maximization to make the venous outflow as big as possible, so that you can achieve a bigger functional graft size than the minimal. So we can do, actually you can safely do liver transplantation even with this kind of unfavorable situations. So there are three ways to modulate the portal flow. You can either ligate the splenic artery, take the spleen out, or you can create a portal cable shunt to divert portal flow into the vena cava. So let's take a look at it one by one. So the splenic artery ligation is relatively easy to do. but the hemodynamic effect of splenic artery ligation is not as good as, not as high as, not as effective as you want. Because once you ligate the splenic artery, the spleen starts looking for the arterial flow. Usually come from gastroepiploic artery or short gastric artery. So the splenic artery ligation does work, but not as effective as it can. Hemiportocable shunt. This is elegant, beautiful technique if you do right. But however, it is very, very, very difficult to control the shunt flow because the pressure in the vena cava is much, much lower than the portal flow. So the controlling the shunt flow is so difficult. And oftentimes you see the portal hypoperfusion because of the portal steer. And based on this data from Nebraska and the UCSF, they were able to reduce the portal flow and the pressure using this technique very significantly. But more than 60% of the patients developed hepatic encephalopathy because of the portal hypoperfusion. And in a few cases, they had to close the shunt. So if you do right, this works really well, but very high risk of the portal steer. And actually, we did this technique in Cleveland as well. We tried in 6 cases in left or right leading transplantation. And actually, we have seen 4 graft failures out of 6 cases within 1 year because it was so difficult to control the shunt flow. And then we have seen a portal hypoperfusion still. So since 2012, we completely abandoned this technique. And a splenectomy is our preferred technique. And as we gain the experience, now we know which patient needs a splenectomy even before implantation. So for example, the graft recipient value weight ratio less than 0.7%, or preoperative sinusoidal pressure less than greater than 16, Merdo score over 20, graft screen volume ratio less than 0.7, donor age over 45, and if you have 2 or more these risk factors, we do a splenectomy even before implantation. So as soon as we open the patient in the operating room, the first thing to do is just to take the spleen out before we start doing hepatectomy. And after hepatectomy, after implantation, and if your spleen is still there, and we just measure all parameters, if we have a very high portal flow, high pressure, very poor hepatic artery flow, we take the spleen after. So this slide summarizes the pros and cons of these 3 techniques. So I don't want to go into detail, but it's very important to find the suitable procedures for your recipient based on the pros and cons. So I have been talking about the graft hyperperfusion. But graft hypoperfusion is also very dangerous. So let's take a look. So the cirrhotic patients, they frequently develop the sizable autosystemic shunt, like a coronary vein shunt or splenorenal shunt. But unless you ligate these shunts at the time of transplant, you have a portal hypoperfusion, and because of the sphere phenomenon. So I give you the one very good example. So we had the 48-year-old recipient with the cryptogenic cirrhosis. So she had a huge spleen. So she had history of ascites and the GI bleed, and but the medicine was only 14. So we gave the left lobe graft, the graft recipient body weight ratio of 0.64%. So this liver was very small, but the donor was 20 years old. So it was a beautiful left lobe graft. So we took the spleen out, but we did not ligate the coronary shunt. We knew there was a shunt. We did not ligate the shunt because after reperfusion of the graft, we measured all parameters: pressure, flow, hepatic artery flow, everything looked perfect. So we thought we did not need to do anything to modulate the portal flow. So we closed the patient, and the patient did well for a few days. So this is the first duplex ultrasound of the portal flow. The kind of basic, but it was flowing towards the liver. It was flowing towards the liver. On post-op day 5, this patient developed a sudden increase in AST ALT. It went up to more than 3,000. We did an ultrasound of the liver. There was a biphasic, bidirectional flowing. And a CT scan shows the patent coronary vein. So this coronary vein was stealing the portal flow, causing the hypoperfusion. So we took her back immediately, ligated shunt, but it was too late. In a few days, the patient needed a retransplantation. But fortunately, she survived. But this is a great example. If you leave the big shunt in the living donor liver transplantation, you may have this complication, and this is devastating. So now let's talk about the outflow. So I think the inflow and outflow has to be equal. The graph. If you have a small outflow, a big inflow, you have a graft congestion. And once you identify your recipient, this recipient either received a partial graft or whole graft, the portal flow is the same. So that means, I think that theoretically, the venous outflow of the living donor liver transplantation should be as wide as the deceased donor liver transplantation. So this is how we augment, we maximize the venous outflow in the transplant graft. So this is a beautiful left lobe graft picture. You can see the left hepatic vein and the middle hepatic vein. So what we do is we just incise the septum and then close the defect with a floating suture. So as you can see, the area of the venous outflow, the left lobe graft becomes twice as big just doing the venoplasty. And out of 100 left lobe graft used, 82% of the graft had the common trunk of the left and middle hepatic. By just doing the venoplasty, you can make this outflow much, much wider. And 18 grafts had the separate left and middle hepatic. But even those anatomy, we can just put together two veins together with the venoplasty. And there were only 2 cases we had to use the vein patch to bridge the 2 veins together. On the recipient side, the surgeons usually close the right hepatic vein and they use only left and the middle hepatic vein of recipient because it gives you the good size match between the donor and the recipient's hepatic vein. But I don't believe this is enough. So this is what we do in Cleveland. So we use all 3 hepatic veins, left, middle, and right hepatic veins. So on this picture, you can see that all hepatic veins are clamped with a vascular clamp, and this is at the native hepatic. We always take the left flank so that you can mobilize the left hepatic vein to the median. So it's easy to clamp, and you can make big venous cuff. So the size of this vein cuff is as wide as the piggyback technique for the deceased donor whole graft. So in Cleveland, the left lobe venous outflow in the living donor transplant is as wide as the deceased donor transplantation. So here is how we do. We do a back table venoplasty, so you can make the donor side bigger. And in the recipient, take the native liver out, and then always take a left flank. So that can give you the good room to put the clamp on. And then the unified 3 hepatic veins all together. Always exclusively use 3 hepatic veins. And there's always size discrepancy in the recipient donor, but always we can safely do anastomosis. And after portal vein, unclamp, and transplant is done. That's simple. Very easy. So this is a right lobe graft with a very big right hepatic vein. But we're gonna make this even bigger. What we do, well, this is a technique I stole from Korea. Cut the right hepatic vein with a liver parenchyma along the vena cava groove. And just to put the vein patch around, halfway around, just to cover the defect of the parenchyma and hepatic. So you can make the outflow on the donor side very big. And as we all know, usually the middle hepatic, the right lobe graft doesn't have a middle hepatic. So segment 5 and 8 needs to be constructed to avoid the congestion of the anterior segment. So here's how we do to create a new middle hepatic graft. But there's a small trick. So here's the segment 5 then. The people say if it's greater than 5 millimeter, just do a reconstruction. But a 5 millimeter is very tiny, like this picture. But this is how you can make this vein much, much bigger. So just to make an incision along the vein, as you can see, side of the opening vein becomes really big. So you can prevent the immediate thrombosis of this middle hepatic. So at the end of the day, this is the waveform of the hepatic vein you want to see after giving a liver transplant. And then as far as you can see, this triphasic waveform, so this is going to promise you leftovers and any living donor transplant. So this slide shows the evolution of our left lobe first. So over the last 2 decades, so we just kept this policy. We used the left lobe graft as a first choice, and I used the right lobe graft as an alternate. In the early days, we used to use the portocable shunt. It didn't work well, as I showed you before. So in 2011, we completely held. We stopped doing the living donor transplantation completely. And then we looked at our technique, and we sent our team to Korea to do some study and train of the living donor liver transplantation. And since 2012, we started adopting splenectomy as a portal inflow modulation. And we started using the new outflow technique. And there was another major change in 2019. We started using the minimally invasive laparoscopic technique for the living technique. So just to increase the donor safety. So based on the surgical technique, there are 3 eras, our 20 years. So we can divide our 20 years into 3 eras. So the first era is before we started using an innovative. The second era is an open donor hepatectomy, but with a recipient with a new technique. And the third era is a laparoscopic donor hepatectomy with recipient, new recipient technique. And interestingly, by doing the laparoscopic minimally invasive hepatectomy, you are not just making a small incision. You are able to reduce the AST, ALT, and even the bilirubin after living. We don't know why this happened, but just by using the minimally invasive, you can reduce the damage, which must be beneficial both for the donor and the recipient. So this is the background data of our adult living donor liver transplant. Across the era, the donor age, recipient age, BMI, Merito score has been comparable, stable. And then about 40 to 50% of the patients receive the left lobe graft, consistent from the beginning to now. As you can see, this is the graft survival. After we started adopting a new surgical technique, the outcome is significantly. And even after we started using a very complex living donor surgery, so we did not compromise our graft survival. So I look for any risk factors for graft failure. And interestingly, so those graft size, donor age, Merito score, those are the surrogates of actual graft size, donor quality, the recipient disease severity. Those are not the risk factors. But the combination of the portal inflow modulation and the venous outflow maximization. Those are very protective. So based on this outcome, so we can clearly say by adapting this surgical technique, we can safely conduct the even in very unfavorable situations. So this is how we overcome side mismatch. The outcome of left lobe and right lobe is comparable, almost identical. And then the graft survival is a smaller graft, is as good as the bigger graft. So here is my last slide. We have been using a left lobe first approach, which help maximize the living donor safety and the recipient outcomes simultaneously. It is very important to understand the concept of functional graft size because it helps you overcome the size mismatch. And then lastly, with the machine perfusion, I think the future application of living donor transplantation should be a moving target. So I think we need to identify which patient really need a transplant from the living donor. I'm looking for that future. Thank you so much for attention, and I'm happy to answer any questions.
Thank you. Thank you, Dr. Hashimoto. Now open to questions. So,
thank you, Koji, for a remarkable presentation. So, congratulations to you and the team on the remarkable work that you've accomplished. A couple of technical questions. Before transplant and during the operation on the recipient, tell me about your measurements that you do for hemodynamics. You measure hepatic wedge pressures before or anything like that, and then during surgery, what do you measure on this? Before implant and after?
So actually, we do measurement before surgery. So as one of the standard recipient evaluation, so we do an IR procedure. We do IR measurement through the transjugular with a transjugular puncture. We measure the wedge pressure and the free pressure of the hepatic vein. So if this pressure gradient is greater than 16, consider the patient has severe.
And how about the recipient intra-op? Before the implant and after the implant, what are the hemodynamic measurements here?
Actually, we don't measure any hemodynamics before implantation.
Okay.
So so as I show you in the
Because you have the
presentation,
pressure.
right? So we measure pressure after implantation,
Okay.
pressure and flow in hepatic.
Okay, and that's with direct pressure in the portal,
Yeah.
right?
Yes.
And then the flows on the hepatic artery in the portal.
Yes. With
Do you do the splenectomy before you plan on it, based on the
Yes.
criteria, or do you wait till you measure, then you do splenectomy?
So the most of the time we do hepatic splenectomy before implantation. So based on those risk factors. So now we know which patient likely to splenectomy. So we basically do a splenectomy first as soon as we go into the abdomen. And then once take the spleen out and then do a hepatic.
Got less portal pressure right away. Okay, thank you.
any other question?
Thanks, Dr. Hashimoto. Great talk. Just a technical question. You mentioned use the outflow for right middle and left, so left lobe graft. You use the same with the right lobe graft. How does that sit in terms of orientation?
So the orientation of the right lobe graft is very different from left lobe. So the left lobe implantation, so the clamp is horizontally placed in the beginning. So the suture, so the basic anastomosis is like this is the piggyback. But for right lobe graft, we have a very big satin skin graft on the venous cave. That we make a large cavotomy from the right hepatic vein to make the size of the vein, a cavotomy 6 or 7 centimeters. So that's the vertical anastomosis compared to the horizontal.
Then you sew the left middle.
So the left middle after reperfusion.
Thank you so much, Dr. Hashimoto. That was an excellent talk, especially since I'm stepping into this space on the side. You ever had any issues with ligating shunt and then being held by the
after ligating the shunt and
Hypoperfusion.
Hypoperfusion.
And then
Hyper.
as a result, having
Hypoperfusion.
Yeah, that's a great
You
question.
go from low to high.
Right, that's a great question. So I have seen that. And after ligating the shunt and the water flow goes really sky high. And then there was a cases we had to do a splenic artery ligation or even taking a splenic. So there was a cases. So, but if you leave the shunts open, the most likely those shunts bother you after transplant. And actually, the hypoperfusion is much more dangerous than the hyperperfusion. As I show you in this presentation, the graft just is destroyed because of hypoperfusion. So I would strongly recommend shunt ligate any size of shunts.
So your approach is as far as portal modulation or splenic side. Do you always perform? Sometimes perform case by case basis?
The splenectomy?
Yeah, splenectomy or splenic artery.
Not always. Not always. Based on the donor, based on all factors, donor age, recipient factors, and pressures, flow volumes. So there are multiple factors out there.
So in the left lobes that you've done, what percentage requires splenic?
About 60%.
60%. And these donors you showed, like 49.5%, were they all adults?
Yeah, for the whole. But we have never seen the serious infection just because of the splenic.
Have you made the official name of the Koji Pentagon or not?
I would say,
Yeah, let's call it.
yeah, Koji slash
Sounds very
Charlie,
nice.
slash
Charlie.
Charlie.
Not just them. He's very humble.
They can think government.
Yeah.
Can I ask you more of a philosophical question, which I don't think is right or wrong answer? Let's say you're living donor with transplant scheduled on Monday morning. On Sunday, you get an offer for this recipient.
Mhm.
It's a 71-year-old DCD, NRP, on OCS, bond making miles, size is good. It's a salvage limb. Taking that into consideration, how would you proceed?
To the same recipient.
To the same
To the same recipient. I would do a living donor, unless this disease donor offer is the perfect excellent.
No for the marginal. No for the marginal liver.
I don't think so. I'd rather give this liver to someone
Different
who
recipient.
doesn't have a donor.
keep the living donor and
Yeah.
then redirect that transplant to something.
But if this the living donor recipient have really good offer, I think we should use it. Yeah. But if there is a marginal graft, I think we should use it. So it doesn't have.
So now, do you think that, I think I would proceed the same way for this way. Do you think that favors more the recipient or donor? If thinking in that type of set?
That's a great question. That's probably the ethical question. I don't know.
Again, I'll tell you what my approach is, and this is 24 years relative speaking. If we have an organ offer for a deceased donor, scheduled for a living, and it's a very good deceased donor, we proceed. But if it's marginal, and the definition of marginal is tricky, but if we think the outcome would be less, then we'll go with the living donor, we tell the patient, and we proceed with the living donor. This has been our So we cancel a couple.
One question in the chat room, actually a question from Dr. Shimoto, Cincinnati, is asking, is splenic artery ligation fails over time as colorectal reform? And then is the next step splenectomy? So like, what? Yeah.
So I think the purpose of inflow modulation is like only for the immediate phase. Once the liver regenerate, so the patient really doesn't need the inflow modulation. Right. So I think if the graft survive 1 or 2 weeks with a splenic artery ligation, I think that is it. I don't know that's what he is asking.
That's a good question, but I think that portal hemodynamic and systemic hemodynamics typically within 6 months to a year almost normalized.
Right.
Not in everybody, but in the majority.
Right.
Which means the need becomes less with time.
But there was a case that we did a splenic cardiolite, so it didn't help much. Then an intra as well. So that's
Sure.
not unusual. That's not unusual.
Interesting.
Any complication from splenectomy, like thrombosis or pancreatic leak or pancreas damage, those complications.
So we don't have a statistically significant difference, but there were cases who had pancreatic leak from the tail, the pancreas. So there was one case we had the gastric perforation. And but
So
they're
that,
not the statistically.
yeah, so it looks like an indication of the splenectomy. You said 60% of left lobe. That requires a lot of experience and knowledge to determine if this patient really needs a splenectomy or not. Right? It's not the uniform, right? So it's mainly like a decision in operative findings and all parameters.
Right. So you don't necessarily to do a splenectomy before implantation. You can just do implantation first and then measure. So probably there were cases that we did not need to do a splenectomy.
Yes.
In the past.
Yeah.
But based on the data, the outcome, those the patient with a very high risk of older donor age, high MELD score, small graft, they probably benefit with a splenectomy.
Dr. Shah said that we have had many fail when the liver grafts are marginal, and then stuck with thinking of what to do next 3-4 months later.
After living donor.
After, I guess that's a living
After living donor.
So
Change the liver.
change the liver.
I don't know. I'm kidding. I'm kidding. I don't know so I don't know. I think each patient is different. But I think his case was probably suffered from severe portal hypertension and unfavorable graft hemodynamics. So I think the best chance you can prevent small bowel size syndrome is before transplant or at the time of transplant. But once you go after transplant, it really don't have a good way to make the situation better. So we have had, so this was not a living donor case, but we had Francis metastascitis. What we do is we sometimes embolize the proximal splenic artery to reduce the pressure. And this is the donor graft. Or place the tips just to make the quality of life.
It seems to me like with living donation, particularly with left graft, it's almost like if you go on a curve, it's a steeper curve of risk. You have to manage it. And in the middle where it's safe, it narrows down compared to right lobe, that safety zone. But it's a zone, meaning there is no black and white. There is kind of navigation in the middle, but it narrows it down to where you have to make some decisions on splenectomy and other things. And you cannot go too far off from that based on your pentagon.
Right.
You have to stay within range and everything moves. So it's not black and white, but you have to really apply yourself, I think, right? And understand the patients.
I'm trying to objectively measure this size of the pentagon.
It's
really hard. It's really hard. There is no way to measure the venous outflow. Yes.
Sorry for the continuous questions. Do you think there's a maximum time out of transplant after the donor transplant or splenectomy or splenic artery ligation or embolization can help? Like what I mean by is
After transplant.
After transplant. Let's say you thought hemodynamics, outflow, all of these things were good, and now the patient 7 weeks later comes back with what looks like symptoms of portal hypoperfusion. But your inflow's okay, your outflow's okay. Hyper. Yeah, with as biomas and small abscesses and things like this. At 7 weeks, is there any benefit to doing a splenectomy, splenic artery embolization, or
I think
for graft cell?
Yeah, I think that doing a splenectomy after transplant is probably not as safe. I think probably to make things worse.
Yeah.
But one thing we can do is embolize the proximal spleen. That should be effective to some extent. So I think that taking the spleen out is probably not a good idea when the patient is having some complication.
Unless you reach point of no return. That's key.
So that's why, so that at the time of transplant, the timing of transplant is the best timing.
With ligation.
Yeah.
It's question on medical.
Right. So you can easily embolize the proximal spleen.
Right.
Yeah.
You just need a good friend in IR.
We have.
We do.
Yeah, we do.
The two people we don't piss off, the GI and at least I.
Right. It's
So it's
also
also because we have anesthesia and pressure.
right. Almost time.
They're part of the week.
Right. Well, thank you for great talk and thank you for visiting Henry Ford. Yeah.